Hi everyone, I wanted to thank the organizers for the invitation to present today. We will review cases and management of fetal SVT. I have no disclosure related to this presentation. So let's start with a case. This is a 34-year-old woman who is G3P2. She was last seen at 19 weeks without any concern. She went back to the OB at 23 weeks to complete the anatomic survey, and the fetus was noted to have a heart rate of 260 beats per minute with eye drops. She was transferred to our institution for further management. On admission, the fetus was noted to be bradycardic to 80 beats per minute. A fetal echo confirmed sinus bradycardia at 80 beats per minute with intermittent PAC, but no SVT during the scan. There was normal biventricular systolic function and trivial AV valve regurgitation. There was a small pericardial effusion and significant ascites. Before going any further, I wanted to review the outcomes of fetal tachycardia. These Kaplan-Meier curves represent a multi-center series of 159 fetus. As you can see, almost 80% of patients with SVT had termination of SVT on follow-up. It is worth noting that this occurred by 10 days after diagnosis in most patients, and only a minority had conversion to sinus rhythm in the first 5 days. Patients with atrial flutter had slower response to transplacental drug therapy and were less likely to have conversion to sinus rhythm, with rhythm control in 25 and 41% at 5 and 10 days versus 50 and 63% for SVT. On the next figure, almost all patients with intermittent SVT had termination of arrhythmia, compared to approximately 70% of those with incessant arrhythmia, with a hazard ratio of 2.6 and 4.9 for SVT and atrial flutter. On the last figure, the presence of fetal eye drop is associated with a lower likelihood of conversion to sinus rhythm than those without eye drops, with a hazard ratio of 1.8, and also a slower time to conversion of 9 versus 4 days. Although arrhythmia can be controlled in all patients, most patients without eye drops do well, with no mortality in this series. The risk of mortality for patients with SVT and eye drops was 17%, including 2 patients with postnatal demise following premature delivery. So to go back to our case, we were very worried about this 23-week fetus with SVT, eye drops, and now sinus bradycardia. Although in sinus rhythm now, we elected to start antiarrhythmic therapy as this was most likely the cause of the eye drops. We chose flecainide for this patient. The patient responded well and fetus converted to sinus rhythm. Unfortunately, the patient represented 2 weeks later with recurrence of SVT. We initially increased our flecainide to 150 mg Q8 hours and then added digoxin due to persistent arrhythmia. At this time, our digoxin level was 0.8 and flecainide level 0.6, but the fetus was still in SVT. SVT was intermittent, although still occurred more than 50% of the time. We thus decided to further increase the dose of antiarrhythmic to 200, 150, and 200 mg of flecainide and 250 microgram of digoxin. This decreased the burden of SVT to now only rare and brief episodes, and thus we discharged the patient home. There is somewhat limited data about the best antiarrhythmic approach, and there continues to be significant variation in practice. Overall, change in management, including switch to a different antiarrhythmic or delivery, was required in 54% of fetus treated with digoxin as first-line therapy, 40% of those treated with flecainide, and 50% of those treated with sotalol. Of note, this series targeted digoxin level close to 2 to get this success rate, which is invariably associated with some maternal side effects. Using multivariate analysis accounting for the presence of eye drops and the pattern of arrhythmia, flecainide and digoxin were superior to sotalol in patients with 1-to-1 SVT, and sotalol superior to digoxin and flecainide for treatment of atrial flutter. Although that prior study did not show differences in outcomes between digoxin and flecainide for treatment of SVT, multiple studies and meta-analysis have found that digoxin was associated with a lower rate of termination of SVT than flecainide, with odds ratio of 0.77. It is relatively well accepted that the lower efficacy of digoxin may be related to poor fetal absorption, especially in the setting of fetal eye drops. This graph represents fetal to maternal digoxin concentration ratio. In case 1, the ratio was low between 0.2 and 0.4. The SVT and eye drops resolved around 28 weeks following injection of amiodarone in the umbilical cord, after which the fetal to maternal digoxin ratio was around 0.8, similar to what is described in non-hydropic fetus in larger series. In case 2, the fetal digoxin level remained low due to persistent arrhythmia and eye drops until delivery by C-section at 32 weeks. Although the poor absorption of digoxin in hydropic fetus is well recognized, the superiority of flecainide appears to extend beyond that. In this meta-analysis, flecainide was superior to digoxin for termination of SVT in both hydropic and non-hydropic fetus, making it a first-line recommendation in many centers. However, this is based on retrospective and non-randomized studies. Prospective randomized clinical trials are ongoing and may help us better answer this question. So returning to our case, our patient came back 10 days later with dizziness, palpitation, and blurry vision. Her digoxin level at that time was 1.7 and flecainide level was 1. Our EKG shown below show new first-degree AV block with PR interval of 250 milliseconds, mildly prolonged QRS of 122 milliseconds, and QTC of 460 milliseconds. She had ST segment changes consistent with digoxin. We held her antiarrhythmic for 24 hours and then transitioned her to Sodlo and restarted lower dose digoxin. Unfortunately, over the next 24 hours, the patient had evidence of second-degree AV block on monitoring, and the digoxin level increased to 2, despite holding her antiarrhythmic. We thus continued with Sodlo as monotherapy, but she had sinus bradycardia to the 40s, for which she was symptomatic with chest pain and dizziness. Even with supratherapeutic and toxic antiarrhythmic level, the fetus was in persistent SVT. At this point, she had partial response to flecainide and digoxin with antiarrhythmic toxicity, most of which was related to the digoxin. She did not tolerate Sodlo due to bradycardia, and we thought she may have a similar response and symptom with amiodarone, and thus elected to go back on flecainide at slightly lower doses. Due to persistent SVT, we cautiously reintroduced digoxin. The fetus has remained in sinus rhythm for the past 2 weeks, and mom had no evidence of antiarrhythmic toxicity with a flecainide level of 0.8 and a digoxin level of 0.8. We continue to monitor her closely and are hoping that we can get her to term pregnancy. Maternal side effects are frequent in the management of fetal SVT and described in approximately a third of cases, although this is likely an underreporting in the setting of mostly retrospective studies. The side effects are those that you know and include nausea, dizziness, visual disturbances, bradycardia, AV block, and Brugada pattern on EKG. Studies have reported more frequent side effects with digoxin than Sodlo, without significant differences between flecainide and digoxin. However, significant side effects requiring discontinuation of medication or decreased dose were mostly seen with digoxin, even though we often think of Sodlo and flecainide as more toxic antiarrhythmic, which are initiated inpatient with telemetry. Now moving on to a second case that was treated almost simultaneously. This woman was found at 30 weeks to have SVT with 1-to-1 AV relationship, moderate ventricular dysfunction, and eye drops. We started treatment with flecainide and digoxin and increased the dose relatively quickly in the setting of fetal eye drop. Unfortunately, mom developed a type 1 Brugada pattern, and thus we had to stop the flecainide. We then transitioned to Sodlo, initially twice a day and increased to 3 times a day after resolution of flecainide toxicity. Despite having episodes of vasovagal syncope at the time of her visit to the fetal center, mom did well without arrhythmia on monitoring. Fortunately, the fetus responded very well and was in sinus rhythm. There has been some controversy with the use of Sodlo in hydropic fetus with SVT. This was a series published in Circulation of 21 fetus treated with Sodlo, including 9 with fetal eye drops. The success rate of Sodlo was 60% in fetus with SVT and 80% in those with atrial flutter. However, the authors reported 3 deaths in the 8 fetus treated with eye drops with a mortality rate of 37%, which is much higher than the reported in the literature. These deaths occurred as sudden event within 2 to 6 days after initiation or increase in the dose of Sodlo, in a pattern concerning for proarrhythmic event. Although there are some controversies around its use in hydropic fetus, our approach is to favor flecainide in hydropic fetus. Sodlo may have a role in fetus that failed flecainide or those with atrial flutter, which are known to respond better, especially if initiated inpatient with continuous monitoring for both mom and the fetus. Fortunately for us, this baby converted back to sinus rhythm. The eye drops and ascites improved on follow-up, although slower than expected. Mom presented again at 34 weeks with decreased fetal movement. The fetus was found to be back in SVT and the biophysical profile was only 2, and thus decision was made for urgent C-section. The baby was in SVT at the time of delivery and was converted to sinus rhythm using esophageal pacing. A few days later, his EKG showed WPW pattern. The baby is now doing well on Sodlol after failing treatment with beta blocker only. To finish, I wanted to quickly review unusual treatment for fetal SVT. Amiodarone has been used with good efficacy, especially in AVRT. Similar to when used in children and adults, it takes a few days of treatment before seeing the effect, with a mean of 6 days, ranging from 2 to 21 for conversion to sinus rhythm. It was also associated with significant fetal side effects, mostly neonatal hypothyroidism. As we often keep amiodarone as a third-line therapy for the sickest fetus, and due to its delay in action, we often end up having to deliver the fetus without having time to try amiodarone. That being said, there is a role for amiodarone in the youngest fetus for whom delivery may not be a viable option. Other reported strategies for the management of refractory cases include intraamniotic, intraperitoneal, or intramuscular administration of antiarrhythmic medication, mostly with digoxin and amiodarone. This was reported in some of the initial series, but with current available option is only rarely needed. The risk of intervention needs to be carefully weighted against the possible benefit and kept for the most immature and refractory cases. Lastly, once every few years, we discuss attempting fetal cardioversion in the most refractory cases. This was reported in the literature with intra-umbilical administration of adenosine. This procedure is at high risk of complication in premature delivery, with a very short duration of action, and thus rarely the favored approach. Successful cases have been reported with concomitant injection of amiodarone to prevent recurrence. We have discussed the possibility of electrical cardioversion with concerns about the limited ability and risk of asynchronous cardioversion for both mom and baby. Other creative colleagues have thought about mechanical stimulation of the atrium with a needle to achieve the same result, but fortunately we have not resorted to those strategies yet. So to conclude, the optimal therapy for fetal SVT remains unclear. The data suggests potential advantages of flecainide for treatment of SVT and Sodlol for atrial flutter, although ongoing randomized clinical trial will provide us more evidence to guide management. Over the past few years, I've learned to be patient in the management of fetal SVT, as results take time. Maternal side effects are frequent, which is worth preparing both families and MFM colleagues about this possibility. And lastly, if it didn't work, keep trying, because many will eventually respond. Others may have some rate control, preventing or improving eye drops, and with careful monitoring may allow to continue pregnancy to term or almost term. Thank you, and I'll be happy to answer any question.